Nick Majerison here. Welcome along to Top Med Talk. And it's time for a brand new series here on Top Med Talk. It's TRIPOM, Trainees with an Interest in Perioperative Medicine. They're reporting from the EBPOM USA Dallas Masters Course, Perioperative Care Practicum, which happened, of course, in March of this year, March the 22nd to the 24th. Make sure you check out ebpom.org/meetings to find out more details of meetings that are being arranged around the world as part of evidence-based perioperative medicine. ebpom.org/meetings. In the meantime, let's have a listen to TRIPOM.
Top Med Talk.
My name's Rob Schiller. I'm a Duke anesthesia resident. I'm here with Bridger Bach, who's also a co-resident of mine.
Hello, everyone.
We are here representing TRIPOM, which is Trainees Interested in Perioperative Medicine. We are here at EBPOM 2019 in Dallas, and we have the great pleasure of speaking with Dr. Dennis Bierle from the Mayo Clinic in Rochester, who is on quite an endeavor. Wouldn't you say so, Bridger?
Absolutely. He was given the small task of creating a perioperative surgical home in approximately, what was it, 6 months?
Not quite. We have a year to start some of the initial phases, but it's going to be a much longer process than that.
Yeah, no small
so.
feat. Yeah.
A couple different questions for you. Why did you ever even consider starting up a perioperative surgical home up in Rochester? What's the need for us to have this?
Yeah. And so this wasn't an idea that I came up with on my own. Where our project comes from has a lot of groundwork over a period of years. And like you might imagine with any large institution like Mayo Clinic, there's a mix of patient need, politics, personalities, weather, etc. that all comes to create an environment where some initiatives can succeed or fail at any given point in time. This is something that's been talked about, but hadn't reached kind of the critical mass from the clinicians taking care of patients with administrative support across the multiple different specialties that need to come together to create this up until really this last fall. We're at a conference, we're talking about how the issues with aging populations, higher risk patients, and really needing to have a platform to intervene on these patients early to improve both short and long-term post-operative outcomes was becoming more acute. And as we were talking about this, came across an intramural funding opportunity, said, hey, let's go throw our hat in there, see if we can get some institutional credibility to try to make some of these changes rather than just being a bunch of guys that you can say, yep, nice chat with you, I got to get off at the next floor.
And Dr. Bierle, what's your background? How did you get interested in this?
So I'm an internist. I did my internal medicine residency in Rochester, and it was I actually almost went into anesthesia.
Almost, huh? We almost got you.
Almost got me. But it was really during my last year of residency where my interest in perioperative medicine crystallized. We have a dedicated rotation, had some great faculty mentors, got plugged in with some projects, and really took off from there. Our model is unique in that our internal medicine group has some fantastic experts in managing high-risk perioperative patients. We don't touch the OR, that's your guys' realm, but making sure that we can identify the risk factors and get the information to optimize patients preoperatively, and so that you guys can make the best anesthetic decisions, and then also providing post-operative care to these patients so our surgeons can do what they're best at, our anesthesia colleagues can do what they're best at.
This is a pretty lofty endeavor. How do you even approach starting something like this? Like, I'm sure there's many different models. Like you said, there's lots of ways patients can present to the operating room. How do you even begin the discussion about starting some sort of framework in which to process these patients?
Yeah, so first, we are approaching this as a quality improvement initiative and recognizing your need. What's the problem that you're trying to solve? As that's going to be different at every institution. And so with our institution, there were probably 20 to 30 different ways someone could get to the OR. Generally, things seem to work pretty well, but when we're looking at things from a system standpoint, especially the high-risk patients and the need to intervene early, we found that we're consistently coming up against the same roadblocks. And so starting with that understanding of your problem really helps as you're going to build a team and build that coalition. And so we were able to identify people who had shared interests across several specialties, both administrators as well as physicians. And then the next step really was trying to get some type of credibility. So whether that's buy-in from your section or division leadership, you're appointed on an institutional committee, or in our case, getting an intramural grant with support from the Department of Medicine as well as some other organizations to advance practice change, really helped to identify this as something that was a strategic need. And so we were finally able to get all of those pieces in place and to really start moving that conversation forward.
And when you're talking about moving this mass critical event, so to speak, I assume that you're reaching across multiple specialties, making this a big multidisciplinary approach. Is that correct?
Yeah. And so there's a lot of specialties that need to be involved, and where we're really in the nascent development of this. So we have internal medicine, we have anesthesia, we're talking with orthopedic surgery, we're talking with data scientists, health science researchers, information technology specialists, operational experts, as well as nursing, physical therapy, and of course our surgeons. So there's several different approaches that we looked at. And so when we're looking at our structure, we have about 65,000 surgeries a year. 16,000 of those are seen by anesthesia or internal medicine in one of the dedicated pre-op clinics. So it's a smaller group. And rather than trying to necessarily go after that whole big piece, looking at what we already do well and who we work well with. And so we can create things that work within our existing structures without disrupting already established service lines. Starting with a small, focused, pilot type of approach, and where we're looking at is with total joints initially to try to use that model, identify champions, and then use the lessons that we've learned from that to try to expand into different surgeries. As each time you add in a different clinical situation, you're adding additional layers of complexity to the system, and that doesn't even include all of the complexities with even changing the position of a period in epic.
Right.
So,
okay. And as a patient goes throughout the perioperative period, who's going to be one of the primary champions for the patient? Like, who's going to be responsible for coordinating activities between the different specialties? Is that going to be an internist? Is it going to be part of the anesthesia team? Does the responsibility fall upon everyone to do that?
You're looking for a quarterback.
Yeah, exactly. Like someone to coordinate all the care.
That's the question in medicine, right?
Here. Yeah, absolutely.
Yeah.
And so that's where my non-perioperative practice comes in. As a faculty member in general internal medicine, we're the Mayo quarterback for somebody who's coming in needing their evaluation for 6 or 7 problems that they've been to 4 or 5 different places for. So that's a role that we already fulfill for our non-perioperative patients. And so that's one of the things that we're looking to change with this perioperative surgical home. We want the surgeons to press the easy button, and everything that needs to get them ready for surgery and then carried through that entire perioperative continuum occurs within a pathway. And so part of our process is who needs to see an internist, who can see an anesthesiologist, who can be seen by an NP or a PA, or who even may just need a nursing screen.
So that's the big question, is how do you tease out of these 65,000 surgeries, who are the high-risk patients that would benefit?
And that is really the next question we're trying to solve. And so we've got ideas on how to structure the pathway with a lot of similarities to the work that's been done by our colleagues at Southampton and also the models that you guys have at Duke. But who are those high-risk patients, and how can we best match our resources to that population that's going to benefit the most? We don't have an answer to that yet, but we're working with some data scientists and health sciences researchers to really use a data-driven approach to try to identify who are those patients, especially in our unique practice where you have a mix of local, regional, national, and international patients.
So for people who are going to be trying to do this at their own institutions in the future, what pitfalls have you come across? What recommendations would you have for anyone trying to implement some sort of care pathway at their hospital?
Absolutely. So we've taken our fair number of lumps. So first is having support from leadership and getting that early if you can. Having champions within the various specialties. And having an operational or administrative partner, especially when you're not given dedicated time and you're kind of doing this on top of your day job. The more that you can get that volunteer army to help you out and distribute some of that workload, the more progress you can maintain. It's also important to set realistic goals and timelines for yourself. We're not, with our project within the first year, we're really focusing on one service line and one small piece of this puzzle. And things that we already have resources for that maybe we can shift rather than reinvent. There's things that we would like to reinvent, but that requires a much broader discussion. And so when you're looking at making some of the changes, trying to reduce how disruptive those are to the overall workflow and using things within your disposal can help start that conversation and start the ball rolling for change. The other important piece is having data, and having data that is accessible and tailored to what you actually want. Like with conversations earlier at this conference with the accessibility of data within the electronic health record, it's there, but it may not be there for your purposes. And so being able to get that information into a form that's usable for you, and so you don't have to keep reinventing the wheel as you're looking at measuring those changes. Because ultimately, at the end of the day, you're going to do all of this work, and you want to be able to say, this is what it did.
As we are at EBPOM listening to some fantastic speakers and topics being discussed, I almost wonder, should this become standard of care?
From our purpose, or from our perspective, that's where we think it should be. It's really an extension of the ARIS discussions and looking at moving the perioperative expertise outside of just the hospital, what gets you in the door and then out of the door. We're really looking at that entire continuum, starting from the contemplation of surgery and all the way through the really as of yet undefined endpoint of when patients transition out of the post-operative period.
Right. Well, we can't thank you enough for sitting down and spending some time talking to us about a very unique experience. Not an easy feat, but I'm sure you guys will be very, very successful.
And it's something that we should follow up on in the future.
Yeah.
Absolutely. It's great talking with you guys and getting an opportunity to share our experiences, and I hope that's helpful to your listeners. And hopefully next time we talk, we'll have some positive results and actually some data that we may be able to share on some of our innovations as
Fantastic.
we move forward.
To be continued, I think. Yeah. Well, this is TRIPOM at EBPOM 2019 Dallas with Top Med Talk. Having a great time. Wish you were here.
Top Med Talk.
Nick Majerison here. Thank you for listening to Top Med Talk. Now, make sure you've subscribed to Top Med Talk on your podcatcher or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Perioperative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.